Good afternoon, and thanks for joining us for our last session for the day on the first day of our Fall Summit on Mental Health. My name's Catherine Reed, and I'm the Director of Education and Content for the Association of Healthcare Journalists. And the subject of this panel is violence in children's mental health, an ongoing U.S. crisis. Children who live in the United States experience more gun violence than children in other developed nations. Hispanic and Black children are significantly more exposed than their white peers. Being injured by firearms, seeing others killed or injured, and or living in a neighborhood where shootings are commonplace all contribute to potentially serious health consequences for children, both in the short and long term. That's the subject of our panel today. Allow me to briefly introduce our panelists in the order that they will speak today, and please submit your questions in the Q&A. We'll have time for those before we end, and then we'll go into the breakout rooms where you can have some one-on-one time with our panelists. Our first speaker is Dr. Aditi Vasan, a pediatrician and researcher at Policy Lab at the Children's Hospital of Philadelphia. Her research focuses on understanding and addressing social determinants of child health, including measuring and mitigating the mental health impacts of neighborhood gun violence exposure. Her research has been published in peer-reviewed journals, including JAMA and JAMA Pediatrics, and featured in media outlets, including The Hill, the Philadelphia Inquirer, and most recently in the Washington Post. Dr. Rosalind Wright is the Horace W. Goldsmith Professor of Life Course Research at the Kravis Children's Hospital, Department of Pediatrics, and Dean for Translational Biomedical Research at the Icahn School of Medicine at Mount Sinai in New York City. Wright is a transdisciplinary life course epidemiologist with a primary interest in prenatal and early childhood predictors of developmental disorders, including asthma, obesity, neurobehavioral outcomes, and antecedents of chronic cardiometabolic disorders. Dr. Polina Krass is a pediatrician at the Children's Hospital of Philadelphia, a Center for Violence Prevention Research Scholar, and an Associate Fellow at the Leonard Davis Institute for Health Economics at the University of Pennsylvania, and a National Clinician Scholar at the University of Pennsylvania. She researches the impact of federal and state policy on adolescent health outcomes, including the intersection between firearm access and adolescent mental health. Dr. Vasan, do you want to get us started?
Sure. So as you heard, my name is Aditi Vasan. I'm a general pediatrician at the Children's Hospital of Philadelphia and a researcher at Policy Lab at CHOP. I'm here today to talk about a recent study that my colleagues and I conducted, looking at the association of neighborhood gun violence with increased mental health-related pediatric emergency room use. My co-authors and I have no financial relationships or conflicts of interest to disclose. So as an overview of my talk today, I'll start by talking about why we were interested in studying the immediate mental health effects of gun violence exposure. I'll talk through our study design and our results, and then I'll end with some implications for practice and policy. We know that gun violence exposure is common among teenagers in the United States. In a survey back in 2015, about 1 in every 8 American teenagers ages 14 to 17 reported having heard or witnessed a shooting. We also know that gun violence disproportionately affects Black and Hispanic children and families. In one survey in 2019, 51% of Black children reported having heard or witnessed a shooting in their neighborhood. And then we also know that gun violence has increased over the past 2 years. Gun sales and violent crime have surged across the country during the pandemic, and you'll hear more about this later. In Philadelphia, where we live and work, 2021 is the most violent year on record, with more than 1,800 shootings, including more than 170 children shot so far this year. And at one of our primary care clinics in West Philadelphia, 70% of pediatric patients, all children ages 0 to 21, have had 1 or more shootings on their block in just the past year. So we know that violence exposure is very common. We also know that violence exposure has long-term effects on children's physical and mental health, and you'll hear more about this from Dr. Wright. Specifically, gun violence exposure has been associated with increased depression, anxiety, and post-traumatic stress disorder. increased rates of internalizing symptoms like withdrawing behavior, and increased rates of externalizing symptoms like disruptive or aggressive behavior. But my colleagues and I were interested in looking at what happens to children in the days or weeks immediately after a shooting. And we wanted to study this both to gather additional evidence, really quantifying the immediate mental health impacts of each shooting that occurs, and also to potentially inform future community-based or health system-based interventions by understanding how children were accessing and interfacing with the health system in the days or weeks immediately after a shooting. We hope to get a better understanding of how shootings affect children's health and potential opportunities where healthcare providers or other adults who interact with these children could intervene. And so our objectives were really first to look at the association between neighborhood violence and children's immediate mental health symptoms. And second, to look at how this exposure varies, this association varies over space and time, as well as with exposure to multiple shootings. So to do this, we looked at more than 128,000 pediatric emergency room encounters for children living in West and South Philadelphia between 2014 and 2018. And we combined two data sets, a data set from our children's hospital looking at emergency room utilization, and then a publicly available data set from Open Data Philly, which is Philadelphia's public data repository, that contained the locations for all police reported shootings in Philadelphia during this time period. Children were included in the study if they lived within a quarter mile of a shooting and had one or more ED visits, emergency room visits, within 60 days of this shooting. And then our primary exposure was living within a quarter mile, which is about 4 to 6 blocks, or an eighth of a mile, which is about 2 to 3 blocks here in Philadelphia of a shooting. And we wanted to pick a group of control or reference children whose other environmental exposures were very similar to our exposed group. So for that reason, we looked at emergency room visits in the 60 days prior to a shooting for children living in these neighborhoods and compared that to ER visits in the 60 days after a shooting. So our goal was to have children who were the same in all ways in terms of their other neighborhood exposures, but have a group that had been exposed to shootings as compared to a group that had not. And then our primary outcome was mental health related emergency room use as defined by either their emergency room chief complaint, and that is assigned by the triage nurse at the time that a patient comes into the ER, or by their primary diagnosis. And their diagnosis is assigned by the provider at the time of admission, discharge, or transfer. So as an example, some of the diagnoses we included were psychiatric emergencies, intentional ingestion, acute stress reaction, anxiety, and depression, and post-traumatic stress disorder. We used multivariable logistic regression models to look at the odds of mental health related emergency room use after a shooting. And we adjusted for several covariates, including children's age, sex, race, ethnicity, insurance, and median household income by zip code. And then because we were interested in looking at variation over space and time, we looked at two geographic buffers, as I mentioned, the smaller group of children living within an eighth of a mile, that's 2 to 3 blocks of a shooting, and the larger group living within a quarter mile. And then we looked at 3 time periods, 14 days, 30 days, and 60 days. This figure shows you the geographic distribution of shootings. And I realize these zip code numbers might be a little bit hard to see, but you can see overall that our study hospital is indicated by this blue star is located in West Philadelphia. And so we deliberately chose the zip codes that were closest in proximity. And you can see that the majority of shootings are concentrated in just a small number of zip codes that are in close proximity to our study hospital. So now on to our results. There were more than 2,600 shootings during our 4-year study period, and most shooting victims were Black men. More than 90% of shootings occurred outdoors, and about 18% had a victim who was fatally injured. And then there were more than 54,000 patients who had 1 or more ER visits in the 60 days before or after a shooting. And these patients were predominantly Black and Medicaid insured. So this table shows you the results of our logistic regression models. We first looked at the 1/8 of a ball buffer, so that's children living within 2 to 3 blocks of a shooting. And we found that at 14 days, they had 1.8 times the odds, so almost twice the odds of coming into the ER for a mental health related complaint or diagnosis. At 30 days, this odds ratio was 1.49, so almost 1.5 times increase. And then at 60 days, it was 1.35. And then for the larger group of children living within a quarter mile, we again saw increased mental health related ER use at 14, 30, and 60 days. And looking at this table as a whole, you can see that children who live closer to a shooting have greater odds of mental health related ER use, and that this increase is greatest in the 2 weeks immediately after the shooting. And then we also looked at exposure to multiple shootings and found, not surprisingly, that children exposed to 2 shootings or children exposed to 3 or more shootings had an even greater increase in their odds of mental health related ER use, suggesting that these exposures really compound themselves and as children are exposed multiple times. So our key findings were that neighborhood gun violence was associated with increased odds of mental health related ER use in the subsequent 60 days. And this association was strongest in the 2 weeks after a shooting for children within 1/8 of a mile, so 2 to 3 blocks of the shooting, and for children exposed to multiple shootings. Although our study only shows an association, and so we can't prove causality, we did think about some potential causal mechanisms. And again, you'll hear more about this from Dr. Wright shortly. But we know that violence exposure can lead to increased physiologic stress and really cause changes in the way that the body functions and performs its normal regulatory functions that could lead to mental health symptoms. In addition, for children with chronic mental health conditions like previous diagnoses of depression or anxiety, being exposed to violence could lead to an exacerbation. And then importantly, violence exposure could lead to a perceived lack of safety and an increased level of anxiety for both children and caregivers, which could either precipitate symptoms or even lead families to seek care in the emergency room for symptoms they might have otherwise managed at home. It's also really important to note that gun violence disproportionately affects Black children and families, and this is in large part due to structural racism and economic disinvestment in Black neighborhoods. The map on the top right is a homeowners lending corporation map from 1937, showing you historically redlined areas of Philadelphia. And the map below that shows you a more recent picture of violent crime in the city. And you can see that the neighborhoods with the highest rates of violent crime are those that were historically redlined. So I think this just underscores the fact that the concentrated violence we're seeing is really a result of concentrated poverty and economic disinvestment that was by design. And so the health impacts of violence exposure could perpetuate racial disparity in child mental health. And for this reason, we think that reducing violence exposure is really key to achieving child health equity. For health systems, we believe our findings really point to the importance of universal trauma-informed care. And I'll talk briefly about what that entails. And we also think they provide support for hospital or clinic community partnerships focused on preventing violence, as well as providing community-based support for children after a shooting. Trauma-informed care really requires recognizing pre-existing trauma and acute stress reactions in children and helping children identify and cope with their emotions. It also involves providing referrals to mental health support for children and their caregivers. And we think that trauma-informed care is really important, not just in the hospital, but really for all adults who interact with children living in these communities. So in their schools and for children who interact with social service agencies, it's really important that children not be punished when they are withdrawn or when they act out, and that these responses instead be seen as natural responses to the trauma that they've been exposed to, and for children to be provided with support and connection to resources instead of being punished for really their physiologic response to what they've had to deal with. For public policy, we think our findings point to the importance of reducing firearm availability, for example, through permit to purchase laws, of implementing place-based structural interventions like vacant lot greening that have been shown to reduce violent crime, specifically in cities, and then increase local government funding for mental health support, because we know that many children who do have this exposure aren't able to access the mental health care they need. I want to mention briefly several limitations of our study. We did focus only on emergency room use, which we think means, if anything, we undercounted the total mental health impact of violence exposure, because many children may have had mental health symptoms that didn't rise to the level of needing to go to the ER. In addition, we looked at only a single chief complaint or primary diagnosis. And so it's possible that children came in for a primary physical complaint or respiratory complaint, but also had mental health symptoms that we just didn't capture in this study. And then importantly, our geographic buffers reflect physical distance between a child's home address and the shooting, but might not reflect the way that residents actually perceive their neighborhood. And because our data was geographic and just looked at the location of a child's home and the location of the shooting, we weren't able to differentiate between different exposure types, like whether the child was home at the time of the shooting or whether they had a relationship with the shooting victim or perpetrator. So in conclusion, we found that neighborhood gun violence has immediate negative effects on children's mental health. And that we think this means that pediatric health systems and city health departments should be partnering with community-based organizations to really support children and families who are exposed to violence. And that policies that reduce neighborhood gun violence and mitigate its mental health impacts really should be a public health priority. I want to acknowledge my fantastic study team, Dr. Hannah Mitchell, Dr. Joel Fine, David Buckler, Dr. Doug Lieb, and Dr. Gina South, who are really fantastic and an integral part of this work. Thanks so much for your time and for the invitation to speak. I really look forward to taking your questions.
Thank you, Dr. Vasan. Very interesting. I'm writing down questions. Okay, Dr. Wright.
Thank you very much for inviting me to participate in this very important symposium. What I'm going to talk to you about is just to remind us all that the mind is connected to the body. And so everything that you just heard from Dr. Vasan, noting how exposure to traumatic stressors like community violence and gun violence can get in and cause mental health problems, it also ultimately can translate to physical health problems. And I am a pulmonologist by clinical training. So one of the diseases I became very interested in as an early investigator was thinking about how psychological factors impact diseases like asthma. Asthma is the most common and costly pediatric illness in this country, and it disproportionately burdens the exact populations that you just heard are also disproportionately impacted by gun violence. For the reasons that Dr. Vasan outlined. And so it really is an interesting paradigm to think about. I have no financial disclosures to disclose. I'm not seeing, there we go. So asthma is a multifactorial disease, and what we know is that it's environmentally driven. And originally I was very focused on physical environmental factors like air pollution, allergens, tobacco smoke, the more traditional things, but it really only, those factors, when you really start looking at them, only explain about 15% of the variance in what drives asthma in this country, and explains the disproportionate burden in these lower income ethnically mixed populations. So I became very interested in psychosocial factors or social determinants. And when I started going out into the communities in the Boston metropolitan area that I was studying at the time and asking them what causes them worry, what causes them stress, violence exposure kept coming up. This was in the late 90s or the early 90s. There was a lot of gang violence going on. People were afraid and concerned about sending their kids to school. And as you heard in the introduction, I'm very interested in understanding the root causes of the onset of asthma. And that took me back to studying women in pregnancy and very early childhood exposures that might translate to asthma risk. Asthma is a childhood disease. 50% manifests by the age of 3 years, 80% by the age of 5 years. So we know you have to look early to see the causes. And so this was a study that I did in Boston at the time that I was at Harvard. We recruited 1,000 pregnant women out of a series of community health centers across the Boston metropolitan area so that we could have diversity across communities, and we targeted communities that had high burden of asthma and those that had low. And if you looked at those communities, they were also characterized by the ones that where you saw more asthma, lower income, ethnically diverse, primarily African-American, Latina, and then those where you see low asthma, high income, mostly Caucasian. And we studied all of these factors that are bubbling around the picture. Sorry. Yeah. Whoop. We studied all of these environmental factors, and I show stress in the red at the top because in the 20 years we've been doing this research, it really is the social determinants or the psychosocial factors that have risen right to the top. I really think it's the big driver here, both independently and actually interacting with these others. And when you think about it, it's the high magnitude stressors that get into the body. I'm sorry, my little button is a little sensitive. So this is, let's visualize how we think psychological stress or exposure to gun violence, concern about gun violence, anxiety around that gets in and gets biologically embedded to cause physical disease. You experience external stressors like we're talking about here, and you, as an individual, you cognitively weigh that against your ability to cope with that stress. And when it overwhelms your ability to cope, either when it's a high magnitude stressor, it's a chronic, constant, uncontrollable, unpredictable stressor, that's where you start to see these key systems in our body that are supposed to protect us from stress and keep us in some optimal balance of functioning to keep us healthy go awry. And what are those key systems? We've all heard of cortisol, the stress hormone that comes from this system called the hypothalamic pituitary adrenal axis, which is pictured on the left. But on the right, you can see the HPA axis. When you disrupt cortisol production because of constant high magnitude stress that you live with, that it disrupts other key systems, autonomic nervous system functioning. So you start to get hyperreactive airways like we see in asthma that triggers asthma exacerbations and symptoms. It also ultimately talks to the immune system. And we know that immune mediated diseases like asthma can really be impacted by stress. So it's a interesting paradigm. This slide just shows you there's now been a whole host of studies that have been done to show that stress, even starting prenatally, will cause onset of asthma as well as exacerbate existing disease once the kids have that. And this cartoon says, you know, why is trauma like living with gun violence, other sorts of violence, interpersonal violence, domestic violence, etc., why does it get so biologically embedded? Because it's really outside of the norm of what a normal human being should be able to tolerate. It's similar to being a combat veteran. You can see on the right-hand side, the Gary Larson cartoon, everybody remembers where they were when Bambi's mother was shot. It gets imprinted into those systems, and that this is something that then can have long-lasting effects and even transmit intergenerationally, as I'll show you with some of the data that we've had. So one of the first studies we did, there was an inner city asthma study being run across the country in several cities across the country, urban cities. And we actually designed this questionnaire to ask them about exposure to community to violence in their communities. These are mothers of young children who have asthma. And we're looking at what predicts poorly controlled asthma in these inner city environments. And this was the inner city asthma study. And you can see that almost a third of people, if you ask them in the last 6 months, were they aware of any of these violent types of events, there was, upward of a third of individuals that had reported these. And if you ask them about hearing gunshots in their neighborhoods and communities, it was even higher. It was upward of 60%, which isn't showed on this slide. We use that simple 5-item community violence exposure scale to actually then look at control of asthma in their kids. And this was published in the American Journal of Public Health some time ago. And what you can see is as the shading goes from light to dark, that's increasing number of those violent types of events reported in their communities, increasing. And you can see that kids who were growing up in communities where there was a higher number of those types of events happening were much more likely to have poorly controlled asthma. And that was regardless of controlling for other types of like negative life events, financial strain, these kinds of things that are more typical day-to-day struggles of these folks. It was really the violence in the community that seemed to be driving it. And it wasn't behavioral. It wasn't because they weren't adherent to their medications or seeing their physicians, et cetera. The next study we did was in the Project on Human Development in Chicago neighborhoods. This was some 343 communities in Chicago that had been well characterized for exposure to community violence, including gun violence, was a major focus there. And they had 3 waves of data following about 3,000 kids. And we wanted to say, if a kid didn't have asthma, lived in a higher community with higher exposure to community violence and gun violence in particular, were they more likely to develop incident disease, controlling for several important other factors that might travel along with that. And we confirmed that, yes, indeed, that predicted incident asthma. But many people said at the time, well, poor neighborhood, high crime violence, also other poor environmental factors travel with that. More air pollution related to traffic, or more dilapidated housing and indoor allergen exposure, et cetera. So we wanted to design a study to actually look at these together. We measured both outdoor traffic related air pollution in a rigorous way, as well as their exposure to community violence. And what we found was, if you see the graphics, the 2 boxes with the lines going up, gun violence is on the left-hand panel, the traffic-related pollution is on the right-hand panel. We put them in the same model, we're adjusting them together in the model, and what we showed was both are important, both are independently associated with increased risk of, in this case, repeated wheeze, which is a marker of asthma, and both had the same magnitude of effect. And so we always think about the air pollution. No one was thinking about the link with the violence exposure. So then we started to try to understand how it gets biologically embedded. And what we did was we took hair samples from our mothers, and we can send it off to the laboratory, and you can measure cortisol levels over the course of pregnancy. We broke it down by trimesters, which we're mapping here by trimester 1, 2, and 3. And we showed that in our sample, the Hispanics and African Americans had higher levels of cortisol production during pregnancy relative to our Caucasian mothers. And the big driver was what's circled there on the bottom. It was actually mom's history herself that she carried into the pregnancy of exposure to traumatic stressors like interpersonal violence. And here we were looking at child abuse. So even remote exposures in the mothers was tracking in these women several years later. And that's important to understand for the kids as well, as we think about the health implications for kids growing up in that setting. Moms also we had them take salivary cortisols, and we showed that moms who lived with higher levels of traumatic stress over their lives had flatter rhythms, shown in that the gray area, flattened, not as steep decline over the course of the day. And that, quite honestly, is very consistent with what someone with depression would look like. So you start to see how the physical changes in the body, how it does translate ultimately to these mental as well as physical health outcomes. This paper showed that increasing exposure in the mothers heading into pregnancy of cumulative interpersonal trauma, traumatic stress, violence exposure over multiple life periods started to program their children's immune system. By the time the kids are born, if mom had experienced it as a child, as a teenager, during the pregnancy, the more periods of time she had experienced something like that or lived in a community with something like that, her kid was more likely to have an asthmatic type of immune phenotype or the way that it's functioning says this kid is going to be at risk if we don't do something about it. Then we followed our young kids. Now we're looking at the kids' exposure from 0 to 6 months of exposures, including traumatic stress. And we took cortisol from the babies when they're 6 months old. And you see that already it's getting embedded in these 6-month-old kids. If they're growing up in communities and homes and families with more of these types of challenges and stressors, they're already showing that atypical cortisol functioning, that HPA axis. And that just showed that it was more likely in girls, but we don't want to go away saying, oh my gosh, unless we can get rid of all, of course we have to do a lot of the things Dr. Vasson was talking about. The upstream things are people cannot be exposed to this. We have to identify what are the factors that are driving more and more communities to see increasing gun violence, et cetera, and how can we mitigate that and prevent these types of exposures. But in the meantime, what do? Well, social support and caregiving environment is very important. And what we've studied in our lab is if moms are able to maintain sensitive, warm caregiving. Now that's a challenge for somebody, right? You're living already in a poor community, you're exposed yourself to these things, you have psychopathology from it, you have your own anxiety, depression. These people want to parent, they want to provide the support for their kids. And if they do, and many of them do, and they maintain it, and if they do, you can totally mitigate the effect on that infant, right? That's not to say we shouldn't be worrying and thinking about what's happening to the baby as well, or the mother as well. I need to go back to this slide because I really want to underscore. Why do I say time's up for trauma-informed research and care? For both mental health, but things like asthma as well. And Dr. Vasson said the same thing. It is another pandemic. With COVID, it has only been exacerbated. We're only seeing gun violence increase. I just saw a special on CNN last night. 50% more gun-related deaths in the city of Chicago in 2020. They're only going to be higher in 2021. There's something, it's the economics, it's all the other things that are going on in the case of this pandemic. And we're only going to see more chronic disease like asthma, like mental health crises, et cetera, and younger people that are going to be lifelong. And it's much easier to build strong children than repair broken men. And we need to do it, and we need to do it early, and the focus on kids is very important. So I'm going to stop there.
Thank you, Dr. Wright. Yeah, that was really interesting. Okay. All right, Dr. Kress.
Hi, everyone. Thank you so much for your time. It is such an honor to be here with Dr. Vasson and Dr. Wright to be talking to you about these issues. I'm going to pivot us a little bit and talk about policy. So I'm going to talk a little bit about firearm injury and death among youth and policies that have evidence to support implementation and kind of prevention strategies. I'm also a pediatrician at the Children's Hospital of Philadelphia and a researcher at the University of Pennsylvania. So this is near and dear to my heart as someone who cares for these children all the time. I have no financial disclosures. So I'll start by talking about the landscape of firearm ownership and injury research in the United States. Then I'll share with you some available evidence about firearm safety in children. And then lastly, we'll pivot to research and policy recommendations. So as you are all very well aware, the rate of firearm death in children in the United States is higher than in any other developed country. In 2019, for the very first time, firearms exceeded motor vehicle accidents as the leading cause of death in youth aged 1 to 19, and that was before COVID-19. Every day, 9 children die from firearms. And for each child that dies, there are 5 children who sustain injuries, and then countless others who are affected by the ripple effects of this violence.
Dr. Kress, I'm sorry to interject. Did you say 2019?
2019.
Okay, thank you.
And unfortunately, federal research on firearms was prohibited for more than 2 decades in the wake of the Dickey Amendment. As of 2018, there have been allocations of funding for research through the CDC and the NIH, but they're small amounts. So relative to lung disease, cancer, and heart disease, for which we're spending upwards of many thousands of dollars per death, when it comes to firearms, we spend $57 per death. And that is not accounting for the 2 decades of lost time to learn more about public health solutions to this crisis. And then, as our speakers have mentioned, the COVID-19 pandemic has exacerbated this issue. So there were 40 million background checks in 2020, which was a 40% increase from 2019. And these aren't folks who previously had guns. We're seeing that the people who bought guns during the COVID-19 pandemic were likely to be new gun owners, people who are purchasing guns for self-defense, meaning that they're less likely to keep those guns stored safely. And then also, we were seeing that these folks were not necessarily being going through the same background check processes as they might have been previously due to delays in background check executions. And as Dr. Wright mentioned, we've already seen causal impact where there's been an increase in firearm-related injury and death during the COVID-19 pandemic. So shifting back to mental health, firearm injury and mental health are tied very much together. And as you all know, child mental health is in crisis. So on October 19th, there was a joint declaration by the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association that there is a national emergency in adolescent mental health. And the important take home here is that the majority of suicide deaths are at the hands of firearms. So 90% of suicide attempts with a gun are fatal, while only 4% of those not involving a gun are fatal. So one of the key things that we can be doing to prevent suicide mortality in children is improving our evidence base for firearm policy. So let's talk about what evidence exists. And I'll say that a lot of what I'm going to be presenting is based on an evidence to action policy brief that I co-authored with folks at the Policy Lab and the Center for Violence Prevention at the Children's Hospital of Philadelphia. And I encourage you to use this QR code to look at the entirety yourself and to stay abreast of the issue as things are changing rapidly. But just to provide an additional frame, so we've talked about how the US has more guns than any country in the world. We know that many children are living in homes with guns. But I think what's most concerning to me is that there is a disconnect between what parents think they are doing in terms of keeping their children safe and what is actually happening. So there was a great study that asked parents whether or not they thought their children knew where their guns were located, and then asked those same children where the guns were located. And they found that 40% of parents were wrong. So they thought their kids didn't know, and their kids knew exactly where these guns were located. And many of these guns are not stored in a safe manner, meaning separately from ammunition and locked such that a child can't access them. So the first policy that has excellent evidence to support widespread implementation addresses this. It's called Child Access Prevention Laws. And these are laws that hold a gun owner accountable if their gun is not stored safely and a child uses, accesses, or could access that gun. And what you can see from this graph here is that when researchers have looked at the impact of CAP laws or child access prevention laws across all intents, they see a 13% decrease in mortality. And when they look at unintentional deaths, so these are deaths from children who are playing with a gun and either harm themselves, a sibling, a playmate, or in the case of older children, cause bystander injury, that led to a 60% decrease with the laws that were most strictly framed. So that is a huge effect in a public health context. Unfortunately, many states have not enacted these laws. And as you can see from the variations of green, only 6 states have enacted the laws that are most compelling, the ones that led to that 60% decrease. So again, I think from an evidence standpoint, we have enough evidence, and now it's up to policymakers to start to enact these laws. The second policy I want to share with you is comprehensive background checks. So as many of you are aware, background checks are basically checking before a gun purchase is made that someone does not have a criminal record, a juvenile delinquency record, an active warrant, or a mental health condition that would make them a high-risk gun owner. And what you can see here is a graph from Everytown Research where they go through the reasons for firearm denial. And you can see the vast majority of reasons that people didn't get firearms were because of felony convictions or indictments, fugitives from justice, or perpetrators of domestic abuse. And I think we can all agree that those are groups of people who should not be accessing firearms. Unfortunately, 22% of gun owners do not undergo background checks, and that's due to loopholes in the way that current background check legislation is enacted. So if you buy a gun online, which is how I buy the majority of things, through a private dealer, like at a gun show, or via private transfer, like a gift, you do not have to undergo a background check unless you live in a state with additional state laws. And so we've shown that in states that do have these extensions that require background checks, even for folks who are not buying their firearm through a licensed dealer, there is a decrease in pediatric morbidity and mortality. I think one thing that's very interesting is that there's been demonstrated that there's a 20% decrease in adolescent gun carrying in states with universal background checks. And that adolescent gun carrying then leads to a decrease in bystander injury, so unintentional injury to bystanders as a result of their access. Finally, I want to talk to you about extreme risk protection orders, or ERPO. These are laws that temporarily prohibit gun purchase and possession by people who are at risk of harming themselves or someone else. And I should caveat that these laws have not been studied in pediatrics, but the adult data is compelling enough that these laws should be enacted by policymakers. So just to give you one example, a study of Connecticut's risk-based gun removal law showed that for every 10 to 20 firearm removal orders issued, there was 1 suicide prevented, which is, again, just a huge effect in the world of public health. Filling in the gaps. So there are many other policies that have been suggested or implemented and even researched, but none of these have the level of evidence to make us say that we should be immediately enacting them. So some of these, just to give you a sense, are increasing the enforcement of illicit possession laws, so possession in those folks under the age of 18, gun safety designs, which make guns look more like iPhones and incorporate things like fingerprint sensors, firearm education for adults, which is licensing and permitting, much like you would have for a fishing license or a boating license, and lost and stolen firearm policies that require someone to share with authorities if their gun has been lost or stolen. These all make sense. My guess is that they might all be effective, but we just don't have the evidence yet. Finally, there are 2 policies that I wanted to call out because of the risk of negative consequences. So the first is firearm education for kids. So this is when we teach children what to do if they see a firearm. And research demonstrates that we can teach a child and have them answer a question correctly. So we say, this is what you do if a firearm's out on the table, and ask them, and they'll be, they'll answer perfectly exactly what they're supposed to do. But then when we put these children in simulations, when we put them in environments and leave guns on that table, children are much less likely to do the right thing. And in fact, as a pediatrician, this aligns well with developmental psychology. So children are naturally curious, and at some ages are really unable to see the consequences of their actions. And so some of this firearm education might actually be counterproductive. So we need to do a lot of research to think about how to target education to youth developmental stages. And then finally, I wanted to talk about prevention of gun carrying in schools. So currently all states except for Massachusetts have a zero tolerance policy, which means that if a youth brings a gun onto school property, they are expelled for at least a year. There is no evidence to suggest that this decreases morbidity or mortality from guns. But unfortunately, there is evidence to suggest that this disproportionately impacts youth of color. So again, in implementing this policy, it is crucial that we are not adding additional layers of racism or discrimination to minoritized youth, and that we're not causing this prison to pipeline that we've seen in a lot of educational settings. So I'd like to end with some research and policy recommendations. So for policymakers, I urge you to implement proven policies, and perhaps more importantly, to increase funding for a comprehensive research agenda so that we can figure out what works and what doesn't work. For providers, folks like myself, we are urging everyone to incorporate firearm safety into routine counseling. And I wanted to clarify that physician communication regarding firearms is protected. So in the past, this was not the case in Florida. There were rules against physicians asking patients about firearms, but those rules were struck down in 2017. So now in every state in this country, a doctor is allowed to ask these questions to their patients. And at CHOP, where I work, we are implementing some of this. We are providing gun locks in both our primary care settings and our emergency departments. And I recognize that you are all journalists, but many of you are parents too, or folks that interact with kids. And so I wanted to share with you the things that we tell our parents in clinic. So the first thing is that if you have a gun, I urge you to store it safely. The second is if your child is going over to someone else's house, ask those parents if they have a gun. And if they do, make sure that it is stored safely. And lastly, if you are parenting a depressed teen, please keep guns out of your house. Then finally, in your role as journalists, we would love for you to spread the word and to increase awareness of this really important topic. I wanted to highlight some resources. The DART Center for Journalism and Trauma at Columbia is an excellent source for trauma-informed journalism. And then at home in Philadelphia, we have a Center for Gun Violence Reporting that also is doing excellent work at how to frame these issues. And then of course, the AAP and healthychildren.org are great resources. And then finally, I just wanted to plug two of the centers that I'm really proud to represent: the CHOP Center for Violence Prevention, which has done direct service work that is trauma-informed and rooted in racial equity for the last decade, that touches on gun safety, but also community violence and so much more. And then the Policy Lab, which I think is a really revolutionary center at CHOP that is focused on anticipating and responding to policy needs using a scientific method. So again, I'd like to thank you. I'd like to offer my email and my Twitter handle for any questions or continued discussion. And of course, to thank the collaborators at CHOP and Penn that have worked with me on some of this research.
Thank you, Dr. Krass. All right, we have some questions. And I'm going to leave mine for the end if we have time, but I want to get to these. So the first question is this: to what extent are clinicians explaining the harms from cortisol overload? How do you undo the harms of too much cortisol for extended periods of time? And who's doing that work? Maybe that's a question, I don't know, Dr. Wright, do you want to start off?
Yeah. I think what clinicians are starting to, we don't do it enough, starting to talk to patients about is validating for patients that stress affects your health. And we need to talk about what in your life, and many times you get to this violence, trauma, this kind of thing, but you normalize it for people. You don't want to ever, I have a patient sitting in front of you who feels like you're stigmatizing them in some way. You don't want to jump right, you know what I mean? And we don't talk, we bring cortisol into it as one of the factors, right? And there's no cortisol level that I can measure as a clinician and really make some action around. But what I talk to people about is, for example, if I'm talking to someone with asthma, I don't want to tell them, this isn't in your head. I think of stress, like these kinds of stressors, community violence, et cetera, as social pollutants. So just as you breathe in an allergen or breathe in tobacco smoke and it moves your immune system in a certain way, there's science to show that so too will these social pollutants. And we need to talk about it. It's a complex conversation. And I'm not a pediatrician. I'm an adult trained pulmonary critical care physician. I sit in pediatrics because I want to do preventive work and have this science translate. And maybe the pediatricians can talk about how they speak to families around that. But that's how I would do it. And I got to tell you, it just my validating it, sitting with a white coat that says, this is important to your health. And they would say to me, Dr. Wright, no one has ever said that to me before. We need to talk about this. Yeah,
I love this idea of stress as a social pollutant, a thing that you're exposed to through no fault of your own. I think there's a lot of judgment sometimes. And I can imagine what that makes a parent feel who is struggling to limit their children's exposure to exactly that pollutant, right? Drs. Vasan or Kras?
Yeah, I would just add that when we are talking to children about this, we talk to them in a developmentally appropriate way about the connection between mind and body, right? So we tell them, if you're nervous for a test, you might feel butterflies in your stomach. And that's because the way that we're feeling about the things around us affects our physical health. And so just like Dr. Wright said, we normalize that connection. We tell them that it's expected that your body should be feeling different ways, that you might be feeling different kinds of emotions after exposures in your environment, and that it's important to share those feelings with trusted adults, with people around you. And then I think for caregivers, we really validate the importance of the care they're providing to their child and say, we know that you can't always limit your child's exposures or control their environment, but just being there as someone who can listen to them, who can care for them, who can provide a consistent, trusted adult in their life is making a huge difference.
Dr. Kras?
I agree. I'll add that I think it is challenging to talk to someone who has this lived experience and might not have the opportunity to prevent it about the chronic impact it is having on their children.
Yes.
And so that is why I think it is up to us as the providers to be trauma informed in our practice, just like Dr. Vasan mentioned. So when I walk into a room, I know that most of the kids I'm talking to aren't in a relaxed state. They're not in the rest and digest state. The chronic trauma has pushed them to the other end of that brain continuum, where often they are in a fight or flight mode. And that might make them irritable. That might make them less willing to think about, or not less willing, but less able even to think about their future and to think about the consequences of their actions. So it's up to me to appropriately respond to that and to be supportive and to develop trust. And I think that as much as possible, if we can validate parents and we can provide them resources to diminish the effect of that, that's like the most important thing that we can be doing as providers.
Yeah. I think also to reassure them that this is what we're doing one-on-one, but rest assured, we know this is a broader problem and there are other things going on that are, I just think being honest with people as well and understanding where you're meeting people like we've been talking about, and respectful of the trauma-informed framework that we need to all be working in. I'm telling you, we could really prevent and actually really decrease the mental health problems in this country, major physical health problems like asthma. Asthma has been recalcitrant to everything we've done. We think we know the biology. We have great drugs. they don't work a lot in this population that we're talking about because that trigger is still there, right?
Right.
That
Right.
it's still there. If you know it's in the background, putting people on edge, like yeah, we were just talking.
Well, it's
You
like
can see
attempting
it.
to treat someone
It's
with
so
a
obvious.
like an antidepressant who has an unaddressed trauma, right? I mean, it's not going to be terribly successful.
Yeah.
To me,
And
there's an analogy there.
I'll just add that I think what we often do, the traditional paradigm, is to be paternalistic and to say, you're not doing the things I told you to do. You're probably not taking your medicines correctly. You're probably, not paying attention to your child's symptoms early enough. And I think what's so important about the work that Dr. Wright and other folks are doing is reframing it for clinicians as no. It's that we don't know how to treat this yet.
Exactly. And we have to understand the science is there. You've heard just a snippet of it here, but just hearing it all just in this symposium, we have to do it. The science is there. You heard it over and over. We need the policymakers. We need to all come to the table, and we can't do it with the biomedical model.
Right. Dr. Vasan, I want to back up with a question about these emergency department visits that you all documented. And so I wonder, how are emergency doctors being trained to do what they can in that environment, which I think is very challenging, or must be very challenging, to at least set the right direction for after that visit? What are they learning? And it's probably impossible to generalize about this, about how to identify that the thing that they're seeing in front of them is very likely, being caused by stress and extreme stress.
Yeah, I think just as Dr. Krass was saying, the most important thing is that every provider should go into the room assuming that the children and family they're seeing have been exposed to trauma and treat them accordingly. And that means, just as Dr. Krass said, recognizing that if a child is irritated or is withdrawn or acts out or is aggressive, that this could be a manifestation of trauma, whether it's recent violent exposure, whether it's something that's more remote, and really working with the child and their family to make them comfortable. I think.
But I think my question is that kind of training widespread?
It's certainly something that we do for our providers here in Philadelphia. Again, recognizing that trauma is incredibly common. Right. I think it's something that should be even more widespread in medical training. It's something that I had for the first time as a pediatric resident, and that I think actually should start really from when students start medical school, knowing that a big part of your job as a clinician is going to be responding to trauma, regardless of the medical field you go into. And so I think certain fields like pediatrics and emergency medicine are probably farther ahead in this space, but really it should be part of everyone's clinical training from the beginning.
Right. It's better, but it's not good enough. Better. It's better in certain, and certainly if you have a local champion, it's better, but it has to be universal. We have to work harder at that.
So these are kind of policy questions coming up here. We live with a lot of guns in this country, as you all have pointed out. What can local elected officials do, and maybe journalists have a role in illuminating this, to address firearm deaths when they're often hamstrung by state level policies?
I can start with that. I think it's a very challenging situation, certainly one that Philadelphia is facing, given the gun violence crisis in our city and some of the differences kind of statewide that have limited enaction of other laws. I think some of the most innovative implementation have come from community informed discussions. And so I think that having community members sitting at the table has helped Philadelphia come up with things that otherwise they wouldn't. And I'll give a couple examples, but the one that that comes to mind is that in the wake of shootings, we now have folks that go out to the block that was affected by the shooting with gun locks. And I think that is so important because it is hard for people to necessarily see the relevance of a gun lock, especially in a setting where you're worried about self-defense, right? That is a setting where you don't want a gun lock.
Right.
Until something happens on their block. And when they see something happening on their block, I think they understand this in a different way. And that is a really important opportunity to intervene. And so I think that sort of policy is really, really important. The other thing I'll share is that Philadelphia has done a great job with just tracking. So part of the reason that Dr. Vasan was able to put together this phenomenal study is because we are openly sharing data on shootings, on homicides, on child death. And until we start doing that nationally, the local city governments aren't going to have the information they need to be able to create those responses. So I would definitely urge folks that are at a local level from the bottom up to start collecting and sharing that data.
Little follow-up for you is, if this person wants to know what the racial and geographic breakdown of these first-time gun owners is, right? You were talking about how many people have bought guns, especially in the last year. Do you happen to know that? What the racial and geographic breakdown is of these first-time gun owners?
No, I don't. I can
Okay.
follow up after. It's still really early data.
Right.
Unfortunately, again, we don't have a registry of everyone who owns a gun in this country for many of the reasons that I stated. And so a lot of this is based on who's getting a background check and the results of surveys, which are still in their earliest phases.
And another policy question, is the decrease in firearm injuries in states with cap laws based purely on awareness of the law, or are there enforcement mechanisms that are assisting with compliance?
That's a great question. We think it's mostly a deterrent. I don't have the hard data to say that this was the percentage that were enforced and how that impacted that incidence rate, but certainly the enforcement is low compared to the impact. So we think mostly it's just a deterrent.
Okay, so for journalists, when it comes to interviewing children and families about violence, what do you think of as the most ethical and non-traumatizing practices that journalists should apply? I don't know if this is feels out of your area of expertise, but I think there are things that you do as clinicians in talking to people that might be really quite relevant to what journalists do when they talk to people who've suffered a trauma. Any thoughts? The Dart Center's got lots of great resources on that, would be my first thought.
Yes. Yes, there are great resources, certainly, that people can refer to. I think really making it clear why you're asking these questions and why you're hoping to amplify their experiences is critical. And I think anytime that we ask families about whether it's trauma they've been exposed to, whether it's their social needs, it's important to make clear that we're asking this for a reason. And the reason is to help them either individually or in this case to tell and amplify their stories and to use them to advocate for policy change. So I think that framing is really critical at the outset. And then I think really encouraging people to share what they're comfortable with and not share beyond that, and acknowledging, before you even start the conversation, we know it can be traumatic and difficult to talk about these things. We also think it's important that other people hear your stories and understand your experiences. And I think if you go at that framing, it's more likely to be well received.
Yeah, I'm really glad you brought up purpose. Like, we should have a purpose for what we're doing if we're going to ask people about a trauma, because as we know, telling your story isn't necessarily therapeutic. In fact, it might be quite the opposite. Oh, this is a long one. I'm going to read this whole thing. In certain organizations, data collection may be done more accurately versus others that may not emphasize the importance of data. How do we encourage more precise collection of data within systems that are overloaded in crisis environments? And then there's a bunch of questions after that. Let's start with that one. How do we encourage more precise collection of data within systems that are overloaded in crisis environments? Dr. Vasan?
Yeah, I think it's hard. And I think, again, we were privileged in Philadelphia that the city prioritizes having this data on police reported shootings publicly available and accessible. I think for a lot of community-based organizations that are doing mental health outreach and support, it is already a lot to be actually providing those services. And when you add the requirement that they're tracking and logging them in some way, that's an extra, amount of effort, and that's time that might go away from providing direct service. I think that some of the solution to that is increased federal funding, right? As you've heard from Dr. Kress, there's more funding now coming out of the CDC and related organizations. And I think that government funding to support these community-based organizations will help them build the infrastructure they need for data and for tracking these outcomes. And ultimately, that's going to be critically important to creating programs that are sustainable, right? That aren't
more funding, more staffing, more bandwidth.
Well,
so funding for research and evaluation.
Dr. Kress alluded to this, right? I believe it was your presentation where you started talking, and I can't remember now, it was Dr. Vasson or Dr. Kress, but you talked about disinvestment in communities. These communities just didn't become this on their own. It was redlining disinvestment. It is time for investment. And the types of data that's coming out of Philadelphia, we need to amplify that and how effective it is, and what the benefit of having that data is, what the benefit of open sharing of that data is, and why a national approach in that way would help us not, the huge health crisis is, right? Link it to the health. That is a big lever, I think. But it's really it's the other side of the coin. It's investment, not disinvestment. More has to happen. It's not enough that $57 for, I forget what you said, but that's not enough.
Right.
To do it. That's exactly right. And as you said, Dr. Wright, we're undoing decades of disinvestment. And so it's going to take decades of concerted, thoughtful investment in these communities.
Yeah, but return on investment is huge. It's not just the short term, that alone is huge, but we're talking long-term implications of this.
Right. What did you say earlier? It's easier to help a child than repair a man. How did you put that?
It's easier to build strong children than repair. When I'm taking care of a person with long-term lung disease that has its roots in childhood as a 40, 50, 60-year-old, I can tweak things only minimally. And that's what was frustrating to me as a pulmonologist. And I would start to think, how far back do I need to go to put people on a more optimal trajectory where we can have bigger swings when we intervene clinically? It really gets rooted that very early. And so you're putting somebody on a trajectory by the age of 5, 6, 7 years old, potentially, of a much poorer, functional life. They're going to have less lung function. They're going to lose it faster. They're going to, be so vulnerable. And clinicians, there are critical windows. We talk about these critical periods of development. And what does that mean? It means a time point in your life where we really have an opportunity to put somebody on a really healthy trajectory. Some of that might be social interventions. It might be enhancing resources to young families, and, let parents provide that caregiving that is so critical an environment to that child. Even a child who has experienced trauma can be hugely impacted by that. Yeah.
So if you could be a signing editor on this subject right now, what do you think the stories are that we've been missing when it comes to violence and children's health? How can reporters do a better job reporting on this topic? What are the stories you'd like to see more of?
I think what we were just saying is, it's the short term is important, but there are long-term implications. There are wounds you can't see that are there, that unless we all, in the medical community included, understand how to approach that individual at that given point and have tools in our toolbox. We've been trained, so we do it, and we can more optimally intervene. But the chronicity and the lifelong costs of it I think is a huge lever. To me, it's a big lever. People, how do we do that as journalists? It's tough for us to communicate that to funders and get funding, and because people want sort of the quick fix.
Right.
What do you do? How do I write a prescription and, it gets better? How do I do a surgical intervention? It gets better. It's not always the case, but there are, we do have, there are things that can be done, and we know they can have long-lasting and cost-effective impact.
Right. So helping people understand really the long-term consequences in terms of costs and actual cost to society, right? Of the actual economic costs beyond the personal costs, because compassion seems to be a fairly unreliable emotion, and it doesn't seem to be the way to reach everyone. So yeah, it's interesting that you've emphasized that point.
Another thing that it was in the literature a while back, and people talked about a contagion effect. Like, you may not be the person that lives in that environment. It affects us all, and here's how it affects us all. It's a contagion effect. I don't know. What do you guys think about that?
I entirely agree. I think that the fact that 50% of children have heard or witnessed a shooting in West Philadelphia is something that should shock us all. And of course, as journalists, you're going to emphasize the case, right? You're going to emphasize the death or the mass shooting. But that ripple effect is omnipresent, and I think could use a little more focus.
I totally agree. And I'll just add the way in which it affects every facet of a child's life. So children in schools who have classrooms where, there are students one day and then there aren't the next, right? What this is like for students, what this is like for teachers. And the last thing I'll say is, I think in the framing of these stories, it's really important to point out not only really how shocking this level of exposure is, but also how incredible these children and families and their communities are in coping with the obstacles that they're facing day to day. And so I think telling stories in a way that points out their resilience, their creativity, the people who are there supporting them day in and day out is really critical, so that they're not just doom and gloom, like this is something horrible that we can't do anything about. You really get a window into the people who are on the ground trying to make this better and the support they need to do their work.
Right. At the neighborhood level, there are these amazing stories. And I learned some of them in Philadelphia, actually. There's been a little pushback about that term resilience, but we don't do enough stories on it. We do more stories on acute trauma than we do on resilience. But the pushback is kind of interesting. It's sort of like, stop celebrating us for our resilience and start helping our communities. So I think
both things are true.
Both things are possible. It's not an either or.
Structural solutions to structural problems. That's certainly true. And these stories should be advocating for structural change. But we also need to celebrate and support the people who are doing the work right now while we wait for the systemic solutions to catch up.
Yeah. Finally, are there any especially effective organizations in the South that are doing preemptive work on gun violence that anyone knows of? Dr. Crass, maybe something that you know about?
I can't think of anything that's specific to the South, so I'd encourage you to look into that, because I'm sure there are grassroots organizations doing great work. But I'll call out every town for gun safety, Brady, as really good Giffords, as really good national organizations that I think are doing a good job of keeping this framed in the evidence and in the science, and trying as much as possible to not be overly politicized.
It's a very hard thing to do in the United States of America. Okay, well, we have like 2 minutes to wrap it up. Any final thoughts on this? Anything you want to share that we didn't talk about? A resource you think that journalists should know about? Okay, well then I guess we can go to breakout rooms, and let's see, I think 60 seconds. Thank you very much, Dr. Vasan, Dr. Wright, Dr. Crass. I'm very glad to have met all three of you. I'm really grateful to Jim McMillan and the Better Gun Violence Reporting Project for having, through his work, sort of opened up my eyes to the way a city is really trying to deal with an incredible problem, complex problem. It seems like Philadelphia is really trying to pull together on this issue. And so I think we will go. Thank you very much.
Thank you for highlighting this very much.